I don't make myself shut up.
Wait a minute, why is mine different?
Alright, you should be looking at this PowerPoint slide right here.
Slide two.
Orders and Blackboard. Alright. These are the words you should know. So we gotta give you, these are the medical terms that you need to know. So review these. And some more. So nystagmus, we hear a lot. Photophobia, be familiar. And the last one is ptosis. Strabismus. Anybody know what strabismus is?
I know nystagmus.
Yeah. That is correct. As you really from the PowerPoint slide, that is. All right, family history. Are some eye disorders genetic?
Yes.
Okay, so you can have blindness, you can have color blindness. You may be predisposed to cataracts, glaucoma. Patient history. What do you want to know about the patient's history?
Smoking,
Smoking.
diabetes.
What else? Diabetes.
They wear
MS?
glasses?
If they wear glasses, so any MS. Why MS?
It's a nerve.
It's a nerve disorder, correct? All right. Hypertension, you may want to know. What else do you want to know? Thyroid. So we're naming off these conditions. What else would you like to know?
Have they had a change in vision?
Are they on medication?
Medications. Have they had a change? Because we talked about cataracts. If they've had a change, what do you want to know about that change? When it happened. Anything they do to make it better? Anything they do to make it worse? Assessment. This week is corner. It's the monkeys.
Oh, this is one thing. Oh,
It's the monkey. Hear no evil, do no evil.
oh, it is. Okay.
Yes.
Sorry.
All right, patient assessment. So you're going to get your baseline vital signs anytime, right? All right, you may want to do that eye test. What is that chart called?
Smelling chart.
All right, remember you said that. Smelling chart, okay? Little kids who have not learned the alphabet yet, you can still do that chart with them. It's shapes. Or it's objects like boats, triangle, whatever they need to do. If you have perfect vision, your vision is what?
20/20.
20/20. All right, if someone has an eye injury, there's this little thing that we give them called a pinhole. You still have to do your vision test, but that pinhole makes the eye focus directly through that hole and does not strain the affected eye, okay? If they wear glasses, please let them do the test with their glasses, because if they can't see, they can't see, all right? Before I had LASIK surgery, the only thing I can tell you was the big E at the top of the chart. And I was like, we're done. You don't give me my glasses back, we're done. So if they have glasses or corrective lenses, let them produce those. All right, this is a little application for you. He's 45, he's diabetic, and he came to your free clinic complaining of eye problems. Give some questions you might want to ask him. When did it start? What else?
Do you know your A1C?
What is your blood sugar running?
What is your blood sugars running? All right, now let's go back to this little scenario. What word is ringing out to you about this clinic?
Free.
So, knowing that, will he possibly know what his blood sugars are?
No.
Because why?
He just can't afford it.
All right, he can't afford it, so he's utilizing your free clinic. Maybe he does know. And if he tells you, maybe he doesn't know numbers, but he says it's been high. What would you like to know about that?
How high? How often?
Do you take any medication?
All right, do you take any medication? Let's go back to that. He said, I just know it's high.
What signs and symptoms?
Signs and symptoms. What are some signs and symptoms of hyperglycemia? You know this.
Poly.
The polys, all right. Polydipsia, polyphagia, polyuria, okay? He may say that he sweats a lot, or, and he's fatigued, okay? You as a nurse, you would know that his blood sugar is high. Somebody said medications. Yes, he may have some medications, but he has not had them filled for a while because he's at what kind of clinic? Okay. And then you may want to ask him also what other comorbidities
pressure.
He's also how old?
45.
45. This is one of the most depressing lectures I've ever done, and you'll see very soon. How are you going to do his eye assessment?
Perla?
Okay, so you're going to give him a Snellen chart, and then that little eye thing that you guys, did you guys play with that last semester? The eye.
No.
Yeah, you did. I thought you did. Or ophthalmoscope?
No.
Oh, no.
We did the ear,
Oh,
but not the
you
eye.
didn't do the eye?
Right.
All right, so maybe get in the lab and play with that, because you're going to look into his eye with that light. You can see a lot of things in there. You can see the retina. You can see some blood vessels. If those blood vessels are filled and engorged, what does that mean to you? What did you
Hypertension?
say? Pressure. So right off the top, you might think he has what? Glaucoma. Also, you may know what other type of condition does he have?
Hypertension.
Hypertension. If you have vessels in the eye, if you see little plaques back there, what does that let you know?
Hyperlipidemia.
Hyperlipidemia. Okay, so he probably may have some coronary artery disease. That's an advanced skill, looking at into somebody's eye and trying to figure out what it looks like. But I know Potter and Perry has it in there. Go back and review that. The eye assessment, it tells you what a senile eye, in this case, senile does not mean memory. It means an older, elderly patient. And we kind of talked about the conditions that he would be at risk for. All right, glaucoma, optical nerve damage, intraocular pressure is IOP. It's prevalent in adults over 40, men, African Americans. Irreversible blindness. There are two types of glaucoma. Let's go back to risk factors. All right, family history, diabetes, cardiovascular disease. Why migraine headaches? Eye pressure. What happens with migraines? You know, who has migraines?
Kids dilate.
What happens to your blood vessels?
They dilate.
They dilate, so that kind of blood pools near your head. It feels like it is going to pop off the top. Okay, nearsightedness. I'm not sure why, but I know it's in your book. Eye trauma. So if somebody has a closed head injury, then they can have that increased intracranial pressure, which is going to increase your intraocular pressure. And prolonged use of corticosteroids. But I think of how that works, I'll just randomly say it, just know that's what I'm talking about. Alright, open angle, closed angle. Closed angle, again, is going to be that common sudden onset. That is a medical emergency. That's someone who's had some kind of head trauma or eye injury. Your baseball players who get whacked in the head with a ball going 90 plus miles an hour, that's that type of closed angle glaucoma. Open angle is bilateral, and the anterior angle, chamber angle is open. So you have the aqueous fluid that's supposed to freely go and flow as it should. And then you have three types. With this one, just know that it's going to affect both eyes, okay? And that the anterior chamber angle is open, and it appears to be normal. So go back and review your anatomy and physiology of the eye and how the aqueous fluid is supposed to go and flow through there. And it's supposed to have a normalized pressure.
So when you say it appears normal, you mean visually, not with the, you know how they do the pressure test?
Right, that's what we're going to get to, how they test for glaucoma. So who's had a test for glaucoma? And what do they put in your eye?
Air.
That puff of air, okay? So if you put that puff of air in there, you're going to see how the fluid is. Everything should be normalized. But if it's that pressure is increased, the, what's the eye guy name? The doctor? Ophthalmologist or ophthalmologist. One does glasses and one can prescribe. So the one who prescribes is usually, sometimes they're both. They can do both, do corrective lenses and give you meds. So he's looking for that, how that air flows through the aqueous fluid and through that chamber. If there's resistance for that air to move or for that fluid to move, then he knows there's increased pressure in there. Alright, you just think about that. I cannot pronounce these words, and I'm not even going to try, okay? Just know that this is what happens. And if I could pronounce them, I would, but they would come out all kind of wrong.
Which one's the air one?
Tonometry.
The first one, tonometry,
Tonometry, ophthalmoscope,
ophthalmoscopy,
gonoscopy,
nanoscopy, and
pyramid.
whatever. So that's that visual field. So you know when you go to the DMV and they flash that stuff, and you're supposed to raise your hand when you see it.
Right.
So think of your perimeter. What do we call this vision?
Peripheral.
Peripheral.
Your peripheral vision. All right. You need to know these medications. Your miotics. Where did you see beta blockers before?
Heart.
So your beta blockers do what to your blood vessels?
Good.
All right. So again, if you never studied for this test, and you know that a beta blocker, you know that from somewhere, and it's a miotic, you know that a beta blocker is going to. So what do you think this class of medication does? Okay, it's going to dilate. So your cholinergics, pilocarpine, what do your anticholinergics do? Can't pee, can't poop, can't spit, all that good stuff. It dries you up, okay? So this is our cholinergic. It's going
Increases.
to increase all the good stuff, all right? It's the fluid, not the moisture in your eye, okay? And your alpha adrenergic and agonist does what?
Works.
Does it work
Works
with you
with.
or against you?
With.
With, okay? And so you kind of know some medications already confirmed, right? Not you. All right. And from your cardiac lecture, infirm, right? Because you learned about an alpha adrenergic agonist, did you not? What's that medication called? Oh, Jesus, never mind. Okay. Moving on. And your adrenergic, what's the difference between your alpha adrenergic and your adrenergic?
The ads
Alpha just does the alpha 1 cells, right?
and the
The adrenergic does all of them?
Or,
And this half of the room is talking and the other half is like, I have. Alright. If you don't know, go back and review those, okay? The difference between your adrenergic and your alpha adrenergics, okay? Because this stuff is not going away. No matter where this medication is used, you still need to know how it works. Some more.
Stimulation to COP.
What was the alpha 1 cells?
You had the miotics and the mydriatics. So if your myotics open, what do you think your mydriatics do?
Close.
Okay, so they constrict your vessels. I didn't put that in here.
Those are an alpha.
I can't even. Can you think of some meds off the top of your head that are the mydriatics?
When you go and have your eyes examined and they dilate your eyes, your pupils are dilated. When they're doing eye exams, they're not in the when you go to get your exams. When they tell you not to drive for a while, that's a mydriatic because the pupils are dilated. Whereas the other one would help drain the fluid, the myotic.
So myotics help drain the fluid, and then your mydriatics are gonna open up make your pupils.
I'm confused.
You just said they closed.
Okay,
Maybe
maybe you did.
it says they dilate the eye. Mydriatic agents or medicines that cause the pupil of the eye to
the
dilate.
pupil to dilate.
They force the dilation. Okay.
Which one causes that?
The
Mydriatic.
mydriatics do the pupils.
And your pupils constrict with the myotic.
Are you going to add that to the selection?
The thing to remember, people, is myotic. It's a little word. It causes constriction of the pupil. Mydriatic's a longer word. It's going to cause dilation of the pupil.
That works.
Patient education. What are you going to teach someone who has glaucoma and they're taking these medications?
Follow up.
Okay, so they need to follow up. If they are taking a beta blocker and they are putting it in their eye, can they not have a systemic effect of a beta blocker?
Yes.
What would you like to teach them when they put that medication in their eye? What's going to prevent that from becoming systemic?
Oh, I don't know.
Yes, your inner canthus. You're going to tell them to put
Oh,
the
that's
eye
right.
drop in and hold the inner canthus here. What's all this in here? It's all vasculature, right? It's all red. So they're going to put those eye drops in and they're going to hold that inner canthus.
That's right.
No, you're holding the eye, so you're constricting.
You're
Not going-
right here. So they're going to put that drop in and then they're going to. So it's just in the eye. If they don't do that, what's going to happen to them?
We go everywhere.
Orthostatic.
Orthostatic hypotension.
Orthostatic hypertension. What else is going to happen? What's going to happen to their heart rate all of a sudden? It
Can
may
go
what?
up.
It may drop and decrease. Okay, are you still tripping off with putting the eye thing in? No.
Tripping off something else.
All right. What else should they do before they put their eye drops in?
Wash your hands.
Before and
After.
all right. Follow-up care. Within these seats. The eye doctor, maybe instead of first diagnosis every 3 months, every 6 months for sure. If they're diabetic, they probably need to go every 3 months. If their hypertension is out of control, maybe they need to see their regular doctor every 3 months, every 6 months, and then hopefully in a nice, perfect medical world, the eye doctor and the primary care physician are in contact with each other, okay? And
That's
they
funny.
can coordinate with each other as to how this person should be followed up. Psychosocial support. What did we learn about glaucoma if this person does not get this under control? What's going to happen? Is it reversible?
No.
All right. So think of someone who, remember, people are getting sicker, younger. So you can have a 15-year-old who is a type 2 diabetic and who also has hypertension. 5 years from 15, they're going to be what? 20. If they have not gotten those diseases under, it's not a trick question. If they don't get those things under control, will they not be at high risk for glaucoma? Could they have possibly be diagnosed right then when they do go see? Damage has been done, correct? So we're already on the slippery slope. Here goes your psychosocial support. What do you know about that age group, 15 to 24 and 25-ish?
Invincible.
They don't listen because they think what?
They're invincible.
And, all right. Older people, they can kind of go with the flow. They know they're getting old. I know Susie's got glaucoma. She takes all these drops. She doesn't drive, you know. But old people still like to get around, right? They do in more ways than one. So for them, independence. So before Susie goes to see Joe, for tea time, she needs to make sure she takes her eye drops a couple hours before time, right? She really needs to make sure she holds the inner canthus of that eye because Susie probably takes a whole host of other medications that can predispose her to some other stuff. So psychosocial support is going to be age specific to whatever. Who was that man you put on your care plan? Erickson.
Beautiful.
I do read them. I just don't know his name.
Let me throw you out a question about this. Application question. You're taking care of a person that has glaucoma. How can you assist them with their ADLs relative to their increasing degradation of the eye, of the aqueous humor, which is they can't see to the side? So what are you going to do?
Because their field of vision.
Turn the
put
lights
it in
on.
their field of vision, which their field of vision is central, right? Also, if you have someone who's elderly who constantly comes in and they may be in this clutter environment and they're constantly falling, that might be an indication they need their peripheral vision checked also.
Somebody said hoarders. Every old person. All right, cataracts. I don't have my iPad. I do have mine. But the cord is gone because of Professor. When we get to class on Tuesday, I'm going to show you something about cataracts. It's, if you got that iDecide, that free app when it was free, you can play with it and figure out what someone with cataracts, how their vision changes, and what their vision looks like once they have a cataract. But if not, we can do that really quickly on Tuesday. 20 million Americans over 40 have cataracts. By age 80, over half of all Americans are affected, and it's the world's leading cause of blindness. So we have gone beyond the borders of the United States of America. We are talking about worldwide. These are your risk factors. Aging, as just as the slide said. Nutritional factors. What are you supposed to eat to help your eyes? Carrots. Carrots, because carrots have what? Beta-carotene. What's so special about beta-carotene? It's an antioxidant? Yeah. Okay. It is. She said don't ask. Antioxidants help our cells do what? Kind of repair themselves and antioxidants.
It's rid of free radicals.
Yeah.
So like blueberries?
Yeah.
Anything. All that good stuff. Associated ocular conditions. What do you think those are? Any other problems? Okay, so we just talked about glaucoma. Toxic factors. Smoking. Smoking's bad in so many different ways. Physical factors. What about if someone is obese?
Mm-hmm.
Does this have a play on that?
Yeah.
Why?
More pressure.
Hypertension.
Metabolic syndrome.
Okay, so it starts a cascade of other things. But if they have more fat than body muscle mass, right? So fat can be anywhere, right?
Even in more pressure.
Yeah. You have vessels in your eye, don't you? So your eyes
sink in when you get really emaciated because the fat behind your eye
is gone. So that sunken, cachectic look, the crypt keeper, when you look like that, you have no fat anywhere. Systemic diseases and syndromes. So like someone who
Lupus.
Malnutrition. So if you are malnourished, you have a whole host of different types of systemic diseases, and then you can get syndrome. So kind of talk about metabolic syndrome, right? Talk about that. Which of these can you change?
Can't STIs be systemic diseases that cause?
Yeah, we're gonna get there.
Yes.
We're gonna get there. We're gonna get
Oh,
there.
that's nice.
All right,
Syphilis can.
symptomology. You're going to learn something very key about these eye things, okay? One thing I did not ask you, do you think glaucoma is painful?
Yeah.
Okay,
That's
but
why they
it-
get to smoke weed, right?
that's why somebody brings that up. I thought we were going to get away from that. Yes, you have to be now a card-carrying member in order to do that legally to help your glaucoma. What is the effects of marijuana? Don't look straight ahead. What do you know about it? What does it do? It helps you do what?
Dilate the eyes.
I honestly
No,
It
just
makes you red.
No, just it makes you mellow. Makes you
How's that card working?
Somebody say,
Munchies.
You'd be allergic
what
to
do you
it.
think it does to your vessels, your blood vessels?
Relaxes the smooth muscle.
I don't know, constricts. I say constricts. No.
I think it hemostasis.
Oh,
0.5.
I know narcotics make you pinpoint.
It makes your pupils pinpoint. Right?
Yeah.
So it.
They
No, I'm talking
constrict.
about your blood vessels.
Oh.
Because
I
it
know.
relaxes smooth
It
muscle.
relaxes your smooth muscles, right? So that's why you kind of like. Watch too. Where's my card? All right, blurry vision. Why is your vision blurry? What does cataract affect? Is it the pupil? Is it the vessel?
I thought it was a lens.
It's the lens. Okay, so just like a camera, your lens is on the top. Reduce visual acuity, sensitivity to glare. Why do you think they have a sensitivity to glare? They have that film over it. Color shift. What do you think white in light colors look like? What color? Grayish or what other color? Blue. Maybe like the grayish, like blue, that family in there. What's astigmatism?
Change in the
eye, right?
Like a
change in the shape.
football. And pain is not a symptomology. Where's glaucoma? They have pain, right? All right, look at that. So if you see this on the test, what's your only treatment?
Surgery.
Surgery. All right. Surgery. This is one of the most treatable diseases ever. Okay. Because with surgery, you should be able to get your vision back. Now, if there's some other underlying factors that you know off the top, and they have surgery to remove the cataract, that part is gone, but their vision in that case is dependent upon whatever else was going on before the cataract. Make sense? All right. So, how many of you have seen, you know how you can tell someone has had cataract surgery by looking at them? Now you know what the eyes go. It's like a little cube. So their pupil, your cornea, iris, it's like a cube.
So when you have like eye surgery or corrective surgery, you can supposedly see like a dark circle, right?
What is cataract?
No.
Yes.
look at your Lord have mercy.
Wake up, Jamie. Okay. You follow us now? Okay.
So,
All right.
I have a question.
About cataract?
Yes,
Okay.
not talking. So my dad had it done. He had both eyes, and he actually didn't have. He always wore glasses, but then his vision improved for like about 3 months, and then went back to his original eye.
Whatever it was.
Yeah.
So plant
you
his
see the near
lens.
side and the far side of prior.
Yeah, it was weird, and we thought, well, maybe he won't need glasses, and then it actually slowly went back down. Yeah, so
Now,
it's
some
interesting.
things, the changes in your vision, you have age-related changes, okay? So as you get older, your vision does start to decline, and you will need corrective lenses. So if you had LASIK surgery, the LASIK repairs whatever your vision problem was. So like for me, it was nearsightedness. I mean, I was like 2 steps above not being able to have LASIK, so that's how blind I was. But he did tell me that as I get older, I still may need corrective lenses due to the aging factors of my eyes. And now little small print starting to irritate me. So I know that
So you're only looking at it once, right?
Right.
no, not necessarily. You can go back and get it again, but it depends on if because they slice your cornea and do it. My cornea was thin, so I couldn't do that. They had to abrade it, correct it, do all the solutions to it. But you can go back. But if they deem that it's age-related changes, there's nothing LASIK is going to do with that. So with your dad, probably the clarity of vision from having the cataracts removed And once all that subsided and inflammation and all that went back to normal, then he has to go back to his corrective lenses. But in the instance, so that's a good example of a predisposing condition plus the cataract, but it did not change his vision.
The cataract is just the film form.
Right,
It's
it's
not the
the
actual like
film.
deterioration from age or whatever.
Right.
It's not accurate.
Oh, no. So pre-op, what do you need to tell this person? What do you want to know pre-op? What do you want to know? Your pre-op doesn't change. If it's a foot, an abdomen, and eye. What is your pre-op?
Allergies.
Allergies, meds. You know what I'm telling them that there may need to be NPO. If this is an older patient, what are some pre-op things they may need to have done? Blood work, what else?
Fluids.
Stress test, or not a stress test, but a what? EKG, okay. They may do fluids in the office. Sometimes I know they do put them on monitors when they do this, because I've gotten patients from the emergency department who, man, wants to get my cataracts done, and they sent me here, and I don't know why. He says something about my heart rate. Oh yeah, your heart rate's 150, and you're an AFib, so boom, no cataracts. They just come up, I'm like, I don't know why. So this is why. Oh, that's what that fluttering was. Post-op. What are you gonna do for them?
Don't they have
Sus.
Cover their eyes. Like,
Okay, so whatever the affected eye is, it needs to be covered. What else? You mentioned monitor. Would you like to monitor them?
Mhm.
They did have surgery, right? So what are you gonna be looking at? Assess. What are you assessing? Okay, the sight, the eye. With some redness and maybe some swelling periorbital, that is normal. Okay. How are they going to be after surgery? Are they going to be laying flat or are they going to be sitting up?
Sitting up.
Sitting up. Why? All right. Too much pressure. No trick questions. Some of this stuff is kind of logical, right? Okay. And then patient education and discharge. What are some of the most important things you need to tell them? Think of your intraocular pressure.
any pain that occurs.
Blowing your nose. And tell them not to do
Anything
that.
strenuous? Come on. What's strenuous? Lifting.
Exercise.
Yeah, I hope you don't do it.
No exercise, yes, no driving. Please just make that a very clear point. No driving. And then we'll try it. What else? What else is strenuous? Coughing. Having to go to the bathroom to do what? To have a bowel movement, okay? Bear down. That causes a vagal response. It's going to increase your intraocular pressure. What else? Think globally, Susie.
Sex.
Thank you.
Ken.
Oh,
Well, nobody else is going to say it.
Who's the guy said that?
Susie the slut.
No sex. You need to tell them that. Is that not just smile and look straight ahead? Is that not strenuous? Okay. So if they have a problem with constipation, what might you want to make sure they have access to? A stool softener. Someone has a problem, males, with BPH, and they have to strain to start. What do you want to make sure that they have? Some kind of medication that they've been taking for that, okay? How can they prevent themselves from having constipation? Because could they not possibly go home on some pain meds?
Fiber.
Fluids. Walking.
Fluids, increase that fluid intake. If you tell them to increase that fiber, you better tell them to increase those fluids, because then they're going to be in the ED with a nice impaction and they're going to be mad at you. Home care. What else do they need to tell them about home?
How to care for their dressing.
How to care for that eye. So, it's a post-op eye. They need to be, what about that whole area?
Terrible.
Don't touch it.
Very clean, okay? When you get to someone's home, sterility is subjective. We know what sterility is, but in someone's home, it's very subjective. So you need to tell them they need to wash their hands anytime they do anything with that eye. If they smoke, try not to. At all costs. You need to cover your eyes, blow it out the window. I don't know what you need to do. What about they have little people at home? Make sure they don't mess with the eye drops. What else you want to tell them?
Not to jump on them or lift them.
Not to what?
Hit mom in the eye.
Not to hit mom in the eye.
Clutter.
No clutter. So some safety issues, right? If they live alone, you want to make sure it's a safe environment. Where should things be as far as them reaching and grabbing stuff? Centrally located, okay? And the lights may need to be what? And dim at first, okay? Anybody ever had eye surgery, you know bright lights are not your friend. So if it's dimly lit, you want to make sure your pathways are clear, they have access to the bathroom, all of those good things. Did we not just have surgery? So what else should they be monitoring for?
Bleeding.
Infection. What are some signs and symptoms that eye surgery did not go so well?
Drainage.
Fever.
Okay, a fever, drainage from that eye, increased pain, okay? I think we came off.
Except for one thing,
Yes.
what these grandkids who say some grandmas had surgery, and what are the grandkids gonna do? Rush to grandma? She wants to pick
Pick 'em
them up.
Don't
And
lift.
she'll pick them up. I don't care if it's the little tinies. That pressure, that action causes the increased pressure.
All right, detached retina. This is a medical emergency. So it's a separation of the, I don't have a from the sensory layer. It's trauma or fibrous scar tissue. So if you have repetitive damage to that eye, it could be from glaucoma. It could be from a previous injury. That scar tissue is going to form and cause pressure and have that retina to become detached. You will hear these, one of two of these. It feels like someone just pulled a shade or closed the curtain over my eye, okay? Or they may see floaters or bright flashing lights.
Or blood goes in the eye, right?
Yeah, that's pretty bad.
I was told, because I had a floater in my eye, that it's a normal process of aging, and that
Do you get migraines too?
no,
'Cause I get auras with them.
no, but the doctor, or the ophthalmologist said, as we age, there's a piece. I can't remember exactly what it was. An artery that dies off when you're like a baby, and that can eventually cross into your field of vision. It was
Basically what
so-
that's saying, what he's saying is kind of right. It is right because the condition is your vascular surface of the eye is separated from the sensory, and if that does not go away at birth, it gets right. You're not getting that blood supply. It's separated, but it could get back into your visual field because those layers are detached. That's why you're getting those floaters because it's blood.
But I think that is different from this.
okay.
Because you're gonna have, I'm like, what?
It's-
I'm not an eye person, and I'm not even gonna profess to say that I remotely know what he's talking about. But hopefully,
I hope he knows what he's talking about.
Right.
I'm like worried.
bright flashing lights, because you brought up a good point. You can have an aura for either a seizure or a migraine headache, and you'll get floaters. Sometimes I'll get flashes of light before I get a migraine. It just depends. But usually, the best person I can use to illustrate this is Amari Stoudemire, the basketball player. He had 2 detached retinas in the same eye. So he has to wear protective eyewear. If that happens to him again in that same eye, he will lose vision in that eye permanently.
And that's from trauma from
His is from repeated trauma and probably some
Sports.
scar tissue. So he's probably caught between a rock and a hard place. So all of your sports people, football. I remember one year a football player lost vision in his eye. The referee threw the flag and somehow it caught him in the eye, and all of this happened, and he ended up losing vision in his eye.
Or it did worse for whatever.
Something like that. Hockey.
oh
Baseball, soccer, little kids just being kids, you know what I'm saying? So, jumping on the trampoline, you smack your head, anything can happen. So but usually the main one is going to be there's something happens in unilateral, just one side of their field of vision is affected. Usually they say it's a shade. It feels like, or someone pulled the shade or a curtain, and sometimes they may have the floaters of the bright flashing lights. What do you know about this? No pain. So which disorders thus far have had no pain?
Cataracts.
Okay, test retina. Retina. All right, macular degeneration. On Tuesday, I'm going to show you with that app what all of this stuff looks like. With someone who has these conditions, what they see. All right, this is the most common cause of visual loss in persons over 60. The little tiny yellow spots is called drusen that you can see. The main things you need to know is that it's the loss of central vision. So when you look at someone, you can see their whole face. So imagine being diagnosed with this and you can no longer see your spouse. That's a good thing, maybe it's good thing. Your grandkids, your friends, your coworkers. So it's like a black dot, and you can see their hair and you can see their clothes, but you can no longer see those facial features anymore. Driving is probably not a good thing. Aging, smoking, because you're smoking and it's messing up all of those vessels, okay, those blood vessels. Hypertension, you're going to increase your intraocular pressure. Talks about being overweight. Some of this is genetics. Your thyroid hormones and hydrochlorothiazide can also predispose you to macular degeneration.
What about alcohol? Because can't the alcoholics, don't they have eye issues? Like your chronic alcoholics?
They will probably be, they could. I know cataracts for sure because they're malnourished and they're not eating anything. They just drinking breakfast. All right, here we are with your conjunctivitis. And Sasha was talking about STIs. You have children, you know that when they are first born, they put these drops in their eye. Erythromycin, do they still use that silver
Yeah.
nitrate stuff? All right. They are protecting them against chlamydia and gonorrhea. No one knows who has prenatal treatment or not, or when they came on board for prenatal treatment. Some of those things are earlier in the game, and some things happen while you are carrying your baby. So your bacterial infection, gonorrhea. What is S. pneumoniae? What do you think that is?
Staph or strep.
Okay. And the Haemophilus influenza, your Staph aureus, chlamydia. This one is going to be your redness, burning. What kind of drainage is that?
Virulent.
All right. And the trachoma is associated with chlamydial conjunctivitis. I know I'm like flying through this. So you have all weekend up until Tuesday to kind of go through your book and go back and look at this stuff. All right. So what you need to know with these conjunctivitis is there's bacterial, there's viral, and we're going to talk about allergic. You need to know what separates each one of these from one another. So, like, two of these things are not the same, one of these things, the whole little song. All right. So, viral, you have your adenovirus. Where did you heard that from? What's the adenovirus?
No, that's the.
What is it?
What's your common cold virus called? Herpes simplex. All right, there's a difference between your different herpes simplexes. 10. Simplex 1 is a what?
Chickenpox.
Cold sore. What's simplex 10? Which herpes
Genital.
is that?
Mm,
There you go. That's your STI and herpes right there. That's not the one you want to share. Shingles is
It's a lead.
zoster. Herpes
What
zoster.
What is simplex 2?
I don't know. I know 1 in 10. I don't know 2 to 8. I don't know 1 in 10. I don't know.
So like chickenpox.
Chickenpox.
So you want 1 in 10 for the herpes?
No, I'm just saying that those are the herpes viruses. You can get herpes zoster in your eye. can't get
Yes.
shingles in your eye.
Yeah. And
That's a
chickenpox.
whole another total different ballgame if you get shingles in your eye.
So I looked when I came back from Vegas.
So this one is your symptomology is a watery discharge, whereas with bacterial, what was up with that discharge?
Yellow.
Purulent, okay? Prominent follicles, where are the follicles? Yes, your eyelashes. You're like, that's a trick question. No. Hair follicles around there. Redness, a foreign body sensation. What does that mean to you?
Feels like something's
Something is in your eye, like a sand or hair or something like that. Eyelid edema, okay? So you're going to have some swelling up here. Oh, Jesus. Epidemic keratoconjunctivitis. It's highly contagious. Got that? It's easy to transmit.
Pink eye.
Yes.
Oh, this is pink eye. Which one's pink eye?
They're all pink
They're
eye.
all pink eye. Conjunctivitis is
Pink
pink eye.
eye.
Yes. And so there's different causes. You have bacterial, you have viral.
I get it. My
Yes.
boys just last week they both had they had pink eyes really, really bad, but they had the purulent, so it was bacterial, and that's why they had to treat them with antibiotics, whereas like they've had pink eye before when it would just drain. It was not like it wouldn't close shut or anything. They would just drain. They were really pink and swollen.
Now, if it's something like the herpes virus, like if it's your shingles in the eye, what kind of medication do you think you're going to be on? Your antiviral, okay? If it is caused by a cold, then what do you think we're going to do?
Nothing.
Nothing. You're just going to treat the symptoms, right?
Decongestant.
What is the number one way to prevent bacterial, viral, or allergic
Hand washing.
hand washing, okay? Allergic. So this can be a part of allergic rhinitis or just something totally separate, okay? But pruritus, what is that? Itching, excessive tearing, string-like mucoid, little white strings. When my youngest was started at 4 months old seasonally, so he was born March, April, May. So like June and July, it would get really bad, and he would just cry, and his eyes were really, really red, and he was tearing, and he would have these little stringy things in his eye. But he was too little for what medication?
Antibiotics. Or
This is allergic.
Antihistamine.
Benadryl. So antihistamine. He was only between 4 and 6 months old, so he couldn't have that yet. So what I had to do for him was a cool towel, and those little mucoid things. That's what was causing his eyes to itch so bad. So I would put the cool towels on him, and he would go. And I would feel so bad, and then I would wet the Q-tip and just kind of take it across his eye, and he was like, "I love you so much." And he did, as he got older, he had eczema, and he has seasonal allergies, really, really bad. And when you get to Professor Britt next semester, she's going to talk about shiners. So children who have allergies can have dark circles around their eyes and look like little shiners. And as he started to grow and get school age, even now I know when his allergies are acting up. And he's dark complected, but his eyes look really, really dark, and you can tell. Toxic results of chemicals. So remember in your chemistry class they had those eye wash stations and all that kind of stuff, and something splashed in your eye. The first thing you're going to do is what? Rinse it out, all right? So in the emergency department, anybody that came in contact with any substance in the eye, if it was splashed or thrown, we are going to irrigate that eye. We put a little, it's called a Morgan lens, and it affixes over the eye, and we hook them up to some normal saline, lay them flat, and we kind of let it run, not wide open, because that's a little harsh. So you just kind of let it gently flow, and it washes the eye out. If they're still complaining of pain, then we may put some little numbing medication in there. What else are we going to be worried about if a toxic substance got in that eye?
Infection.
Blindness. So some kind of alteration in their vision. So after we kind of get them to the point where they can possibly do a vision acuity test, you want to make sure that you do that. Then the physician may do a slit lamp thing on them and really look at that eye. And then you're going to put this little ultraviolet dye in their eyes, so it's gonna illuminate anything that's wrong with like the cornea. So if they have a scratched cornea or any portion of the eye, when the physician uses that lamp, it's gonna illuminate. Sometimes it helps them find a foreign body. So think of someone who does shop work, so like sawdust or even metalworking. You get those little shards of metal in your eye. We're gonna use that. So here, everything we already talked about. Why are we giving corticosteroids?
Increase the inflammation.
Okay, it's going to decrease the inflammation. So everything you guys already know about, right? Antibiotics. Whatever the causative agent is, you're going to give an antibiotic that's specific for that. Cold compresses, corticosteroids, allergy medications. What are some of those?
Benadryl.
Benadryl. What else?
Claritin.
Zyrtec. Claritin, Allegra. All right. Saline or sterile water, irrigation, and analgesics. And again, you already told me that it's patient teaching is hand washing. Also, your co-workers, hand washing. What time is it?
One thing I need to say too is age specific. You need to teach some things about with conjunctivitis. Teenagers, the girls don't share mascara. And if with certain shades, people share shades. You know, especially the girls, they're vague. They share shades, and any drainage can get
You
up
need
to
to
the
say
shade.
sunglasses, but some of them aren't.
I knew what you meant.
Y'all don't know what shade. Sunglasses, excuse me. Okay, and you know, anything that can get to the hair follicles and then get into the eyes.
All right. Any questions about eye disorders? Which ones have pain?
Cataract.
All right. So, how do you know someone has a detached retina? What is one thing they may say?
Curtain.
Okay, the shade or the curtain. All right, and they lose vision in how many fields? Unilateral. So that means one. What's so special about cataracts?
Fixable by surgery.
It's fixable. What is the only way it's fixable?
Surgery.
All right. You already know about pre, post-op, and discharge planning and teaching. Macular degeneration. What does that mean? Old age.
Central.
So they're over 60. And what is lost to them?
Central vision.
Central vision. With those persons, we're going to be worried more so about what support for them, what kind of support. Psychosocial support, okay? And then interventions in the home to kind of keep them safe. But first and foremost, it's probably going to be your psychosocial. All right, here's some more things you need to know. If you have teenagers or tweens, as they call them now, you might want to go over this slide with them, okay? There's a difference between deafness and hearing loss, all right? Teenagers will, I didn't hear you. And selective hearing. Please go over these terms. I'm saying this for a reason. Please go over these terms. Yes, ma'am.
Aren't they saying nowadays too, like, we're going to have a lot more people with hearing problems due to the earphones for the iPhones and stuff?
Oh, yes. Yes, yes. If we don't talk about it today, most definitely we'll talk about it on Tuesday. Now, what is that last one say? What is that?
Presbycusis.
There you go.
Old age.
Say it again. Say it loud.
Old age.
Presbycusis.
Oh, that word.
That word. I'm not saying it again, and I only said it because I heard somebody else say it first. All right, this one. Restitution. I don't know. Restitution. Progressive hearing loss associated with aging. So teenagers are not in this category, okay? Conductive versus sensory neural. One is nerve. Okay? One is the transmission of sound that can be medically or surgically corrected. If it is a nerve issue, what does it say? So your hearing is what? It's gone.
Well, I'm confused about the cannot be the cochlear.
That does
That's
not
middle ear.
change the fact that they've lost that nerve
Okay.
innervation and damage. It just gives them another way to be able to heal.
Okay.
Because without the cochlear implant,
There's-
they don't have any.
Is your cranial nerve is destroyed?
Yes.
Done. So there's no way for it to get to your brain.
Nope. Or in organ damage.
That's the.
All right. Same thing does not change. The nursing assessment does not change for these disorders because there are a lot of things that are predetermined by genetics. So family history. For some reason, there could be some type of genetic anomaly where hearing loss is genetic. You want to know your patient history. What do you want to know?
Smoking.
Smoking again. What else do you want to know?
Where they worked at.
Where they work, such as where? The airport.
Factories.
Private. What did you say? Industrial. In the hospital. Who's at risk for hearing loss? MRIs. Ever been to that room?
No.
Make sure you want to poke your eyes out. Just heck aloud. They give you, if you're a patient, they give you earplugs. That's why they're in a room, not even with you, behind the wall with glass, and they're waving at you. You're like, really? Like, and that weighs on you. Where else? What else do you want to know about your patient? What kind of metal?
What would you say? I'm sorry.
I'm thinking metal, but in a whole total different way.
Oh,
Rock.
rock
Rock
concert.
band.
Yeah.
Everybody who has to get front row seats and front row tickets, those speakers are like as large as this little console here and super loud. If it's not rock, it could be Lady Gaga, it could be Jay-Z, it could be anybody, okay? Those vibrations, those decibels, and you're that close. Sasha also brought up a good point. When I was growing up, you had your earphones, the headphones that actually came over your head, okay? And then if you were a girly girl like me, you put them on there so it wouldn't hurt. But now, where do you put it?
Earbuds.
In your ear. And my youngest son, whose room was like 2 doors down, I could hear his music. And I'm like, Sean, turn it down.
It was in his ears that loud.
I go in his room, he got earbuds in.
Oh.
Really pissed off. So who has to pay for him to get hearing aids? No. So I'm like, turn it down. What? Exactly. If I can hear what song you listen to and can sing along and I don't even know the song, that's a problem. What else do young people do and some people my age that's too old to do this?
Welcome to.
Explosives.
What?
He said blow things up. That's what I heard going. Well, okay.
All right, you're involved.
What do you want?
And I'm in my car.
Loud.
Should I hear your bass?
No.
Your car?
Maybe.
I hope not. So I drive a nice little Saturn truck. You sit in your car and you start going like, look. I'm not listening to anything. And you look down and it's this itty bitty car. And a
Rims.
like this. And I'm like, there's another idiot that's gonna be deaf that I'm gonna have to take care of. So these are all the things, all the different ways. He said blow up stuff. This is my next venture in life is to learn how to properly shoot a firearm. So if you're ever on campus and you can hear them on the shooting range, and the shooting range is way over there, what do you think it sounds like when you're actually firing the firearm? You should have to wear your ear guards, right? Okay. Assessment. What are you going to assess?
When did it
How well they hear.
How well they can hear, right? So remember, did you guys do the forks and the Weber and Ryan test?
Oh, yeah.
You sit it up there, and if it vibrated in both ears or whatever, you can sit it back here and all of the things. I know it's in Potter Perry, and I know it's also in your textbook. Go back over that and review those. But what else can cause a hearing loss?
Infections.
Infection.
Oh,
So
and toxicity too.
yes,
Medications.
toxic
Does
medication.
Aspirin?
I know tinnitus is ringing in the ears, but can that cause hearing loss?
Because tinnitus is usually associated with something else. So you need to figure out what that something else is. So that's kind of like
People live that way. People live with that.
Well, yeah, they do. We're going to talk about some conditions on here that may cause them to have tinnitus forever. So, who is predisposed to getting infections all the time?
Babies.
Okay, so the little people, what do they get put in their ears? Drops, and if they continuously have chronic ear infections, they get what?
Tubes.
The tubes. All right, Professor Britt's going to tell you all about that, but you can't say you didn't know. When you assess the ear, what would you like to do to that ear? Look at it. All right, so you need to get in there. What are we looking for? Any obstruction or drainage, okay? Waxes, okay? If your wax is like this hard and you can't even get the scope in there, we've got a problem. Some people say they can't hear, and then the doctor's like, you need to irrigate their ears and all this stuff. Out. I'm like, oh my God, I can hear them. Okay.
My sister has excessive earwax buildup. She has to go to the doctor regularly because they have this metal thing and they like go and take all
That wax out. If it's so hard, I mean, it can be like that hard that you have to irrigate it. All right.
I want to say one thing.
Yes.
There is one condition or situation where you will not want to irrigate that ear. If some child puts a pea or any type of vegetable or anything that can absorb water, it's going to make the hearing loss increase. So any vegetable or anything.
So like your beans, your peas. One time my brother took the stuffing. He took the stuffing from a chair and pushed it down into his ear. It was made out of cotton. So do you think they could irrigate his ear? No, I don't know how they got it out of there, but the doctor was like, he did a very good job of getting it way down in there. How do you know that your patient has hearing loss?
What?
Exactly.
Who?
Or what would you notice them doing? Reading, turning their head or looking at you to try to read your lips. Or they're constantly saying, huh? What? What do teenagers do anyway?
Huh?
Mumble. What do they do with the TV?
Turn up.
Turn it up, okay? Little kids, they do, no, they don't get that. But they may rock or something. What's the little kids when they can't hear?
When they can't hear, they try to do movement.
Yeah, I don't know why they're little kids. But it has something to do with the sensory perception of them trying to move to maybe able to catch the sound waves. Again, that's Professor Rich, but again, you can't say no. All right, we talked about what are some causes of hearing loss, and we kind of talked about some health promotion and educational pieces. Otitis externa. Extern. What? Versus intern.
Outer.
Outer. Okay. Otitis is your what?
Ear canal.
Ear-itis.
Inflammation.
All right. So it's the ear inflammation on the outside. Swimmer's ear. External auditory canal, water in the ear. You can have bacterial or fungal infections. So someone who goes swimming in like freshwater places, lakes, rivers, in a swimming pool, probably, hopefully, bacterial versus fungal. They're going to have pain, all that good stuff. All of this is going to be inflamed. It is very, very painful. That ear looks like somebody literally set it on fire. That's how red and inflamed it is. All of your lymph nodes back here, what do you think they're going to be?
Flame.
Okay, so they're going to be large. A little painful, a little swollen, a little irritated. So, I keep saying pain, right? So in this case, your priority is going to be your patient's what? Pain. So we're going to give them some analgesics. And then we're going to give them antibiotics or antifungals and the corticosteroids. That's going to help with what?
Inflammation.
Inflammation.
Well, you know how some doctors say that antibiotics don't treat your earaches for chronic
chronic earaches? How do they know if it's, bacterial or just an earache?
Well, this one is different because this one's on the outside. You're talking about otitis media, the middle ear infection. And some now pediatricians are starting to back away from antibiotics. One reason is because everything is so antibiotic resistant. But back in the day, they didn't give out antibiotics. They let the body heal itself.
Yeah.
And if the eardrum needed to relieve the pressure, what do you think it would do?
It ruptured.
It ruptured, and the body naturally healed it and repaired it, and life was good. All right, so your nursing implications don't change. Patient teaching, medications, home care, follow-up, infection control. What is one way to do infection control?
Wash your hands.
What's the other way to do infection control in relation to medications?
Don't share.
Take them all till they're gone and
Don't share.
share. If you hang with me a little longer, we might be able to get this whole thing done. Okay? All right. This is your otitis media. Acute, lasts less than 6 weeks. So little people, especially if they go to daycare, which is one of the didn't like it when my kids went to daycare, because me, the good mommy, would give my kids their medication as they would and send them to the daycare. Then you had, not that they were bad mommies, they just didn't follow directions as well. The only time they would get their medication was when do you think?
When they were at
When
the
they're at daycare. So then they would go home and they wouldn't get the medication. So then you never ever got rid of your ear infections. Those are your causative agents. You know that they're going to have pain, fever, drainage. You're going to look into that ear and see if it's inflamed. You may also be able to see fluid. How you know it's fluid in there, if you can't see it, you're going to see like a reflection off of your tympanic membrane. Because it should be nice and opaque, and you should be able to let light shine right on there. If it kind of bounces back at you, then you know you got a little fluid in there. Babies, how do we know they have an ear infection? They can't talk.
Pull their
They
ears.
pull. What else do they do? They're not cry. They cry.
They don't want to
what?
lay down either.
When you lay them down, and what else do they cry?
They don't want to
Eating.
eat.
They don't want to eat because how do they eat? They
Sucking.
suck a bottle. Laying flat and sucking does what? Increases that pressure. Usually they can, they may start out with a cold or like a little virus, and it turns into what? An ear infection. They're so small, there's really not much of a travel range in between our little sinuses in the ears, right? So if they are all congested and they can't blow their nose yet, you have to do everything for them. So if they're also congested and it can't come out, isn't that going to back up? You can't see it backing up into the ear, so it's going to sit there. As it sits and marinates, what's going to grow? Bacteria. Okay? So then for them, you're going to give them the antibiotics, and this is your those are your tubes. So they'll cut into the eardrum, and they'll put the tubes in. The tube should fall out on their own. As they get older and it starts to grow and heal, the tube will fall out. So if you find a tube in the bed sometime later, that's okay. It's a problem if they just had it done and you go in there and the tube falls out. One thing you want to know for someone who has a middle ear infection is if they have drainage coming out of that ear, what do you want to know about it?
Color.
What color?
How
Smell.
much?
How much and what else?
Odor.
Yes, you can smell. I could smell my kids' ears and tell that they had an ear infection. You can kind of smell it. It smells a little sweet. You're like, ooh, no, it's not right. Take them to the doctor. They've got an ear infection. If they have a fluid that they say something coming out of my ear, but I can't see it. It doesn't have a color to it. What would you think? Okay. Clear. But it's coming out, and they say I no longer have pain.
Eardrum burst.
Eardrum rupture. Okay.
Not always clear.
Huh?
Not always clear.
Not always clear. It all depends on what was growing up in there. It could be yellow. It could be green. And that color is going to be very, very sweet. If they say, I was having pain a couple of days ago. Now I don't have any pain, but just kind of get this, little clear drainage, or all this stuff is now profusely running out of my ear, then the key thing is that they did have pain, they no longer have pain, and now they're having some type of discharge. That lets you know that their eardrum has ruptured. All right. Meniere's disease. Abnormal inner ear fluid balance. What do you know about balance in the inner ear?
Where it
Kind
is.
of go together, right? We had a teacher in high school. I think she had this. She was so mean, director. What some of the basketball players would do on purpose because she had this inner ear problem is they would run past her. And of course she would be like off balance. And then she would curse them and then run down. But 50% of it is patient family history. So again, here genetics comes into play. It can be predisposed by some illness of some type, and it's often misdiagnosed for a very, very long time. Because as you can see, it mimics some other stuff. Down here, tinnitus is what? Ringing in the ears. Vertigo?
Dizziness.
Has anyone ever had vertigo by itself? That sucks. It's like you're off balance and the room is doing one of these numbers and you're nauseated, you're throwing up, you're sweating, you can't hear, you may have the ringing of the ears. So this by itself here could be this condition there. Okay? Could you imagine your hearing going in and out and you had these symptoms all the time? Some people live like this for months, even years before it's diagnosed. And by this time, we've gone into, so sensory neural, we know that they have done what here?
Nerve damage.
Permanent hearing loss, okay? Sometimes they're a candidate for a hearing aid and sometimes they're not, depending on how severe the damage is. If this is an abnormal inner ear fluid balance, what are some things you want to teach your patient? Rise slowly. What else? Avoid what? True. If you have little kids and you're doing something or you hear a crash, what is your natural
Jump up
inclination
real
to do?
quick. Oh, no.
Should I do that? If I have no sudden jerky movements, right? What about flying on an airplane?
Oh no.
That might be a
bad.
little problematic, okay? But if we don't have a definite diagnosis of Meniere's disease, there are some things that we can do. Meclizine or antivirus. What does that do? What do you think?
Anti-vertigo?
Anti-vertigo. You want to know why? Because it makes you sleepy.
Oh, nice.
No. Valium. It kind of relaxes you, right? Okay. Promethazine or phenergan.
Nausea?
Nausea, anti-nausea. What are some other anti-nausea medications that you know of? Zofran. You may have compazine. Hydrochlorothiazide, HCTZ. What did you learn about that before?
Diuretic?
Okay, so why are we giving a diuretic to someone who has an ear problem?
Fluid?
Okay, so the excess fluid. If it's not Valium, what other PAM can you give them?
Clorazepam?
Lorazepam. Lorazepam is what? The Ativan? All right, ototoxicity. Well, this is nice. Ototoxicity means what? Toxicity of the ear. And these are your causative agents. But in the previous slide, what did we give you?
Diuretic.
All right. So diuretics can cause ototoxicity. Your chemotherapy agent, anti-inflammatory agents, like what? Aspirin. When did we learn that we give aspirin all the time? All right. So your MRI, your CAD patients, right? Chemicals. So some people who have these metal allergies, or maybe they work around different chemicals. Can you not get things through your skin?
Mm-hmm.
So if you're touching something all the time, can you not build up a toxic level of that agent. Most people forget about that. You always think you have to ingest it for it to be toxic, but you can touch it or be around it, breathe it in. If it gives off fumes, you can still have a toxic level in your body. So, your vancomycin, erythromycin, gentamicin, do you not see this all the time in the hospital? These people are receiving all these high-powered antibiotics, and they are causing ototoxicity. So, if your patient is on vancomycin and you initiate the infusion and you go and you come back and check on them, what statement might they give that will prompt you to stop that infusion?
Couldn't hear.
Can you repeat that?
Okay, I got it.
Good one.
But first and foremost, they're going to say what? They have ringing in the ears. Hopefully they're not saying that already. You only started it a little while ago. So that ringing in the ears, your first nursing action is to do what?
Stop the
Stop the infusion. Because that ringing in the ears means what?
ototoxicity.
Now, there's another way to prevent that because there are some labs that go with vancomycin. What are they?
No, no.
Your vancomycin and your jets. Yes, there you go. Your peak and trough. It is your responsibility as a nurse to make sure you're checking those labs. So, peak means what?
Highest therapeutic.
Okay, and your trough is
Lower.
so you need to check those before you give it. Even though nowadays pharmacy doses your Vanco and your gentamicin. We used to do it back in the day. But even though they are dosing that, you still need to be on top of those labs. And if it's the high end of normal, I would call the physician unless they've already given parameters and let them know, this is what peak and trough were, whatever, what do you want me to do? And then he may say, go ahead and give it. You need to chart physician aware of blah, 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 blah. Stage 2 continue with the next dose. And if I were you, I would be in there all the time, checking on that patient, making sure they're not becoming toxic, okay? What other labs do you think would alert us to the fact that this person may be becoming toxic, even if their lab values are okay? Urine and creatinine, all right? Because that's your kidney function, right? And if that's starting to decline, those levels might elevate and clue you in on that too. So pharmacy is also supposed to be watching those levels, but then again, it is your responsibility as a nurse. We kind of talked about the metals, your lead, your gold, and your mercury. So ladies, if you're buying earrings, what do you notice about a lot of the earrings now? Stainless steel, they're nickel free, they're mercury free, all those kind of things, because people were not only allergic to it, but were becoming toxic. All right, your assistive devices. Hearing aids you know about. They're becoming more and more cute now. They're not those big old honking things that stick up this high to the back of your ear. I saw on the news yesterday as I was getting ready for work, but I really didn't have time to dwell on it. But it's something for kids, and it's really, really cool. And it's a hearing device and they have it, guys, like as a superhero. And you never think of little kids with hearing problems, right? But this little boy had a hearing problem, and the device kind of sits in the ear, and nobody knows about it, and he can hear. And he was just the happiest little guy ever. Because kids are mean, and if they can see that hearing aid, then what do you think is going to happen? They're going to be made fun of. Anyone. It's an image issue, right? No one wants anyone else to know something is wrong with them. So if I have a hearing aid, I'm different, right? And you could tell when the hearing aid was too loud because you got up close on it. Like, oh, okay, turn it down. Or they never had batteries in them. You're like, Mr. Jones, do you have your hearing aids in? It's like, what? He's like, you're like, and you open it up, and you're like, I'll be right back. And you put the battery in one. Mr. Jones, why are you shouting? Can you do? So then you time to get rid of the other one and you change the batteries. Whoop, life is good. Okay? Anybody ever seen a pocket talker? What does it look like?
It's headphone. It's a little box with a little microphone on top.
Yeah, some of the, you know, depending on where they dropped in what era with their hearing problem, you may see a pocket talker. I got to see one in nursing school. I was like, is he recording me? But that was his way of being able to hear because Bert was like 90 some odd years old, and he didn't want hearing aids because Bert was 90, so he was still kind of cute to be 90. So with hearing aids, what does that mean to the little ladies? He's old.
Good.
That's what I need. That makes him feel a little better. I mean, and then you can be more kind of coy with the talking to the microphone. Alright. Some questions in the on-screen mode. Alright, your implant. Has anyone ever seen one of those?
Yes.
Okay, if you watch, what's my favorite soap opera? Young and the Restless. There is a gentleman on there, he had meningitis, and he lost his hearing from that, and he has a cochlear implant. And then there's this new surgery out where they can actually go in and do something with the nerves of the ear, kind of like reinnervate it, and he got his hearing back. I know that's soap opera wrong, but apparently it's a true surgery because, like, hearing loss is one of his little platforms, and he did come back on and talk about it and told you to go to somebody's website. And when I'm not in school, I don't write that kind of stuff down. But the surgery is really real. A hearing guide dog. What other kind of guide dog do you know?
Seeing eye.
Seeing eye dog. What is the hearing eye? The hearing guide dog.
Like for cars, danger.
Doorbells.
Doorbells. What else? Smoke alarms. All those kind of things. One thing I did not talk about when we were talking about Meniere's disease, what kind of diets do you think you need to teach these people?
No salt.
Low sodium. Where is sodium?
Everywhere.
Processed food. Where else? Everywhere. You need to break it down.
Canned foods.
Canned foods. Where's our processed food? Where's
Frozen.
everybody's favorite place?
McDonald's.
Fast food. Where else? Restaurants. Somebody said, I heard it up here. Lunch meat. Anything you can pop in the microwave. What about your frozen?
Oh, those are the worst.
I thought I was doing good until I turned over one of those nice little healthy meals and looked at the sodium content and was like, pluck a duck. I've been doing. Nobody ever, and you teach this stuff, but you're like, da 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 da, and then I'm like, let me turn this over. Oh my God. That's like 23% of my daily intake. I'm only on one little stupid little meal that's going to keep me full for an hour. So you have to teach your patients all of those kinds of things. Now, anybody with hearing or, okay, kind of just went talked about that. So if they have hearing aids and they still work by battery, they need to have working batteries. They need to keep their ears clean. When you're teaching people how to clean their ears, what is that most irritating commercial where he just puts the Q-tip in his ear? Like, ah! Yeah, the wax back. Okay, that whole whatever. But you know, teach people to put stuff down into the ear canal. Q-tips, bobby pins, paper clips, you name it. If it can clean it, they're gonna put it in there. You have allergies and your ear itches. You just want to get to itch. So if your finger can't get there, you're gonna try to put something in there, and you don't want to puncture that ear drum. Any questions, comments, or concerns about your eye and ear lecture? That's everything in a nutshell.
We don't have Trader Vic's frozen.
No.
Okay, let me throw you a question real quick. Okay, Meniere's. Choose all that apply. So what all would be included relative to the treatment of Meniere's? It would be antihypertensive. It would be diuretics. It would be low sodium diet. And what else? What other meds? Dextromol, diuretics, antihypertensive, anti-vertigo,
Yeah.
And the volume.
and low sodium diet in the valley. Okay?
Go to class and know the med.
Who's it is?
Next Friday. Class.
Oh, your freaking critical thinking.
I didn't know.
We do it next time.
Can we just have an extension on it?
Yeah, well, you can.
Okay, we'll talk about it Tuesday when it's